webinar. And today we'll be hearing from Doug Romer up in La Grande, Oregon. But I want to show you a little bit about what we have available to you here and then tell you about our next webinar, which will be information and education that's available from the ARC. And I cannot remember that acronym, but they've got a lot of training, CMEs, they've got some documents and some really interesting stuff available. So we've asked them to come and share that information with you next month. In our Adobe Connect screen that's on your computer monitor right now, we've got several different modules that I'd like to walk you through quickly. The NRTRC presentation is where you can, well, I don't know what that is, Martha. But the save the date postcard down here is, you can download that and take a look. That's our an announcement of our upcoming regional conference. I'm sorry, I'm tripping over my own tongue here.
The presentation is the copy of the slides in
That is
PDF.
slides. Okay. Yeah, I was thrown by the 2013-2, but so you can see Doug's slides here. It's a PDF copy, so you can download them and read them real easily. In the bottom module, we have some links that we can get you some information. One is on the conference, one is our website. You're welcome to look around that. Then we have a link to sign up for our bi-monthly newsletter, which contains telemedicine, telehealth information from the region. And then there's a link to SurveyMonkey. And SurveyMonkey, we ask you that you complete a little survey on the webinar today and what you thought of it. And we also solicit comments for what you believe would be a good webinar topic, something you'd like to have us present. I am just in the process now of starting my 2014 schedule, and I would love to hear from you to see what you would like to hear from us. Then along the bottom row, you have a chat module where you can make comments back and forth if you need to, and a question and answer module in which you can type questions for Doug, and Doug will answer as he goes along if the question is pertinent at that point. Otherwise, he'll go back at the end of the discussion and read through them and give you the answers. We are not doing a live audio for this because we've encountered some echo problems, so we've decided to avoid that problem by not enabling any more audio than we need to. So let me start off and introduce Doug Romer. I've got to tell you, I've known Doug for a long time, so I'm going to kind of read a little bit about his status right now and then tell you a little story on Doug. Doug is the the executive director of patient care services and chief nursing officer at Grand Ronde Hospital in La Grande, Oregon. And Grand Ronde is a 25-bed critical access hospital. I was just over there a couple of weeks ago and got the grand tour, and Doug is going to show you some things that he's doing that are just amazing for a critical access hospital, and he's doing it all using telemedicine. He's got 35 years of experience in the healthcare industry, and that ranges from surgical services management to performance improvement, accreditation, and licensure. And he's on the board of directors of the NRTRC. I first met Doug at an ATA meeting in Las Vegas, and he came up to me and started telling me about his program. And I have seldom seen anyone as enthusiastic about a telehealth program as Doug was. And he had just started working with a robot system and was using that in a pediatric ICU, if I remember right. And he told me how excited the kids were, and I could see through his eyes how excited he was. So this is going to be a great presentation to show you how a critical access hospital, a small hospital in a small town, can benefit from telemedicine. So Doug, take it away.
Thanks, Bob, and thank you everybody for coming, and I'll hope to show you a few things about what a little hospital can do with telemedicine, and in fact any hospital can do it with telemedicine, and couldn't do it without some very good partners, and you'll see as we move along. We got started in this whole process with St. Alphonsus Regional Medical Center in Boise, Idaho, and continued to grow from there. Anyway, I want to give you my disclosures. I don't have any financial responsibilities or hookups with anybody other than Grand Mountain Hospital. I have one employer, and I do have two telehealth advisory board memberships that I hold. One for, as Bob said, the NRTRC, which I'm very happy and pleased to get to be around so many talented individuals. And the second one is the Telehealth Alliance of Oregon, and I'll highlight a little bit later on what the Telehealth Alliance of Oregon has done. These are two complementary organizations, and if you ever have an opportunity to interface with either one of these, it is really will be worth your time. Okay, so we went and developed a telemedicine program, and the thing about it was very, very easy, simply because we were following our Board of Trustees mission statement to provide access to high quality, cost effective healthcare. And as you know, in rural areas, access is a big deal. And actually, as the physician specialty shortage is out there, access in a urban area is also difficult, where somebody may have a specialist in the town or community that they live in, but that person may be backed up with appointments and you can't get in to see them for a while. Well, we think that telehealth is a way to make their practices more efficient and provide access to more patients. And I'll share how that works in our clinics in a little while, and you'll see, and you can comment if it makes sense or not to you. Why would anybody want to ever leave LeGrand? This is an actual front page. It's been a year ago. I was getting ready for a different presentation, and I saw that. I walked. This is from the hospital. The Red Cross drugstore gives us free newspapers for the patients, and I walked by and I saw, wow, watch out for snakes. And there's a picture of a rattlesnake on top. And then there's in big bold letters, cougar killed in LeGrand. And actually, a cougar had came into town and bedded down at the Catholic Church underneath the sign of the Catholic Church. And they chased it off down by the railroad tracks, and they had to kill it. And because, you know, you don't want cougars hanging around the kids' Sunday school. And then the other one on there is genetic testing confirms wolf. Well, for some strange unknown reason, somebody had shot a wolf in town or in our region, and they had to do an autopsy and make sure it was indeed a wolf. And you know, wolves are protected, and nobody knows how that happened, but it apparently did happen. And the one other thing on this front page that you can see right there, it says the wagon train tours area. And LeGrand is on the Oregon Trail. And in fact, the Oregon Trail runs right behind Grand Mountain Hospital. And we can walk out our back door and walk up the hill, and not very far, we can see wagon trail ruts from the actual wagon trains going across the mountain there. And if you take a little walk back a little bit farther, you can see a cross where somebody had died on the trip and was buried there. So that's LeGrand. Now, why would anybody want to leave LeGrand and get their health care anywhere else when they can stay here with all this wildlife? So anyway, from a rural perspective, you know, why telehealth? Why does telehealth work? And it's easy. We have, it says it improves quality by the use of specialty physicians. We have some very, very good medical staff that live in our community, and we have quite a wide variety of medical staff. We're pretty sophisticated for a 25-bed critical access hospital, meaning we have 3 OB-GYNs, a couple of orthopedic surgeons, some general surgeons, urology, a neurologist, podiatry, anesthesiology. We have a good breadth of surgical specialties and primary care specialties. We actually have a hospitalist program, which I'll tell you a little bit more about soon. But I think one of the hallmarks of a good physician is not being too proud to ask for help and not being too proud to consult a specialist if you need it. And our docs are very good that way, and they're going to do what's ever right that will provide the better care for our patients. And keeping the healthcare dollars in the community is a big one for us. It's kind of like you hear these shop locally ads of you know, make sure you shop locally, you know, don't just use the internet for your purchases. And we would like to think that as the community continues to use our hospital, we'll continue to grow, we'll continue to get good at what we do, and make everybody happy and provide good outcomes. And we are providing good outcomes. anyway, it's a reputation promoter for both the remote and the distant site. The remote site, both sides can say that, boy, we have outreach or we get specialty coverage, and it does work for us that way. And if grandma can get her care taken in the ICU when she's very, very sick and on a ventilator, certainly it's okay for her to come to the same hospital and have her gallbladder out. And we look at it as providing a full breadth of services for our patients. And we're doing that via telemedicine. And I'll show you our program. Um, there are, I put it into 4 buckets of what we have to consider to have a successful program: the infrastructure, advocacy, partnerships, and culture. And the infrastructure, one thing I didn't list here beyond consents, connectivity, releases, contracting, is legal. And as we have worked with many different organizations, both big and small and private and networks, we have learned to love legal and how that we need to get everything cleared through the legal department. And the bigger the hospital, the bigger the legal department. And sometimes that can become a roadblock. Sometimes you can use what you find on other contracts with other providers and streamline processes. But legal is a big deal of infrastructure. And the other piece, telemedicine is getting more and more mainstream. But 5 and 6 years ago when we started, it wasn't. It was relatively new, and people would raise their eyebrows, and at least in the way we were using it, and ask a lot of questions. And so I feel for us to continue to develop telemedicine and prove how well it works and how much better it is for the facilities and the patients is advocacy. And that's kind of what I'm doing here, is I'm sharing what works, what doesn't work, and how partnerships can be developed. And that's part of all of our roles as the NRTRC board, is to take some time to go to the Lions, go to the Optimists, go to community organizations, and tell them what we're doing and how we're doing it, and why that they are lucky to have such a successful program in their community. It's important to choose the right partners, and some people, even now, some organizations really don't get it, or specialties within a large organization don't get it. You may have a medical center, and you have one department that's really open to telemedicine and wants to get it going and sees the vision and wants to make it work. But yet you might have a different specialty in that same hospital where the culture isn't the same and they don't really embrace it. And it's getting easier and easier, but it's not a slam dunk by any means. And then within an organization, it takes a while to develop a culture of telemedicine. And I've been lucky enough to see that transformation in our small hospital, where at medical staff meetings, it comes up and says, well, can we do that via telemedicine? And so people are always thinking that maybe there's a better way to do it. And when you live in a small facility, you don't have a very deep bench, and you need to have somebody to back you up, because if you're going to offer a specialty like, I'll give you an example, oncology. Our small hospital is lucky enough to have an oncologist, but that oncologist has a whole group of patients, and when he leaves on continuing education or for vacation, which everybody deserves, he needs somebody to take care of his patients. And so rather than have those patients go and travel far, far away and get their treatment plan continued, we were able to develop a telemedicine relationship with the folks at St. Alphonsus, and those oncologists cover our patients when our oncologist is gone. And so it's kind of a network, and likewise, if the need arose, our oncologist could help cover a clinic for them if we needed to. But they've done many clinics for us, and it's proving very successful. So this is what a remote presence health system looks like. Now, everybody's been familiar with hub and spoke. And the hub and spoke is where you have the one main provider being the hub, which we started out with St. Alphonsus being the hub. They still do a very large amount of our telemedicine, but we've been able to branch out and become providers of telemedicine for other people and be recipients of telemedicine from organizations other than St. Alphonsus. So these are the things that we're doing, and I tell you, this is not, there actually might be one or two other boxes that could fit on here, but I can't fit them on the slide, and I don't know how to do it. So I'm just going to kind of talk a little bit about this one, and how I broke it up was consulting services and outpatient services and then other services. And I think the way that I am going to break this up is take the education pieces out of here, but they are developed, they are brought to our community via telemedicine links, and so they kind of are, but they're education, and in a roundabout way they are patient care, but they aren't actually patient and doctor face to face. So maybe some of those will go away, and I'll add the other bubbles that need to be in there. But let me tell you about the televisit programs. That's the first top one there on the left, is that we started our very first televisit program with St. Alphonsus for neonatal intensive care patients who our babies would get flown from La Grande to Boise, and then the mom would have to stay behind, because more times than not, when the mom delivers a premature infant, it's via C-section, and the mom cannot just get out of bed and go with her baby. Usually what happens is the helicopter comes. First we do a neonatal intensive care consult. The pediatrician and the neonatologist get together in the nursery, and they talk about the baby, and sometimes they say, well, this baby can stay or this baby can go. But when they go, the baby's gone before the mom wakes up from her anesthesia. And therefore, the dad's gone, the baby's gone, and here's the mom here. Sometimes the family goes, everybody goes with the baby, the infant. And so the mom is kind of stuck here wishing she could be there to see her baby and bond with her baby. Well, what we've been able to do with that is the televisit program. And if we were providing this instructional session in another format, I could play you a video where the neonatologist goes into great detail on how the mother's baby's doing, and what this line's for, and what this tube is for, and how we're breathing for the baby, and all of that. But I can tell you that the moms are so relieved when they get the opportunity for a televisit, and to visit with, then they get to see their husband, and they get to see the other family that left with the baby, and get to bond with their babies. And the technology that we use is so easy to use that we've been able to just leave the laptop in the room, and depending on the mom, if she is computer savvy, we can show her how to log on and how to zoom the camera and how to take a picture and how that all works. And I remember last Thanksgiving we had one of these televisits, and I came in and got her set up, and I quickly found out that this was a savvy mom and she knew how to do it, and I just left the laptop with her for the weekend. And when she came back, or when I came back, she had a whole hard drive full of pictures and videos and conversations that then we burned to a DVD and gave to her. And so she did have some of the first weeks or days of her baby's life documented, and that worked out real well. The other television programs we've done are with other hospitals throughout Oregon. For different reasons, we've been able to do those visits. And I can remember one that we did at OHSU, where a lady contacted us and said, my grandpa came to your hospital and was very, very sick and got flown to OHSU for throat surgery. And I was wondering if I can see my grandpa. And I said, sure. And I let her into my office and logged her in and showed her how to zoom the camera and how to talk. And the grandma was in the room with the grandpa, and they talked and talked and talked. And I kind of went out in the hallway to give them some privacy and came back in 15 minutes, and they were still talking. And I left for another 5 minutes, and they were still talking. And finally I came in and I said, okay, I think we better call this one a good visit now. And so the granddaughter says to her grandpa, I love you, Grandpa. And the grandpa had a tracheostomy and he couldn't talk, but he lipped back to her, I love you. And everybody was crying on that one. And it's just one of those things, because in order for this granddaughter to get to see her granddad, she would have to take a couple of days off work and drive to Portland, stay in a hotel, eat out in a restaurant, and navigate the way through the halls at OHSU. And it's just a wonderful thing. And there's a lot of stories that we've done with those. And And some might say that's not telemedicine, but I would argue with that because there's a lot of healing that comes along with getting to be close to your loved ones when you're in an illness situation. The way we got started with this whole program was with a perioperative training program. Is St. Alphonsus wrote a grant, Department of Defense grant, and with the concept that we could train operating room nurses from remotely with a nurse educator, and let's try it. And so they developed this program, and we successfully trained 4 OR nurses that way. Now, I've been an OR manager for years, and I can tell you that we have attempted to train many more than 4 unsuccessfully, where we had the program where they would go and do the AORN, Association of Operating Room Nurses, didactic training online, and then have a nurse educator on the other end that would run these nurses through a curriculum and with the robot in the room and critique them after they would do their surgical cases, and it's been very successful. So those are, that's how we really got started. Then we do foreign language. We use the robot for foreign language. And if somebody has a need for interpretation, we have an 800 number that we call, and the Passport for Languages in Portland, Oregon will beam in and facilitate communication between the foreign-speaking patient and the nurse or physician. And we use that quite a little bit. The other one that we use is sign language. We use the same system for sign language, and it's the Center for Hearing and Deafness in Seattle, Washington. It used to be called Sign On, but they've changed their name, and it's a different organization. And they have access to our robot, and when we have interpretation needs for sign language, they do it there. And as you can see, there's a whole list of other things. I'm going to kind of move along, otherwise I'm going to run out of time to do this, but we'll kind of continue to talk on these. There's a lot of talk these days about the triple aim. The triple aim is better health for the population, better care for the individuals, and lower cost by improvement. And I can say that we help meet the triple aim with telemedicine. We do congestive heart failure and diabetic teaching. We do community education via telemedicine. The better care for the individuals. The example here is our ICU intensivist support. We get our most critical patients taken care of by intensivists from St. Louis, Missouri, or New York City, New York. We have 2 pods that Advanced ICU can take care of our patients from. Also, better care for the individuals is endocrinology. We have an endocrinologist that a lot of our patients would go to endocrinology in Walla Walla, which is 86 miles away. But what the endocrinologist found was she had a very high no-show rate from patients from La Grande because it was over the mountain, 86 miles, took an hour and a half to get there. And so she joined on to our telemedicine clinic and helped us do that. And the no-show rate is much less, and patients are getting better care because they're able to see their physician. Okay. Dermatology is another one example of better care for the individuals. Somebody will come and get their lesions looked at if it just means coming across town to the local clinic. They may not be as apt to get early treatment if they have to drive to the dermatologist miles and miles away. And another example of better care is Parkinson's televisions. We have a neurology program with OHSU in Portland where they take care of advanced Parkinson's patients, and we do that here and saves those patients. It takes some days to go there, and maybe if I have time, I'll tell you a little story about that as we get going. Sorry for the noise in the background. The helicopter's landing right behind me. And then the lower cost by improvement. You can read that, what that's about, and these slides are available. So, okay, here's an example I want to share with you is our ICU program. In 64 months, we saved 69 patient transfers. These are clearly patients that would have had to get in a helicopter and fly out of La Grande because they didn't have the intensivist support. Now, we've taken care of many more patients than 69, but these are 69 patients we can actually check the box and say, this patient would not stay in our hospital if we would not have had telemedicine support. And it really has been phenomenal how well accepted it is by the physicians and the patient's family. When you're in a rural hospital, patients our family, they're always wondering, can I get better care if I go to a medical center? And that's a question you ask, and they sometimes ask their doctors, maybe I should be transferred to OHSU or St. Alphonsus. And but when we have a telemedicine intensivist on staff providing care for those patients, that question is never asked. They feel that they're getting the best care possible, and we know that we're providing the best care possible. To the point that even in some, it used to be what we do here. Sometimes patients get really, really sick, and they aren't able to get well, and you know they're not able to get well. Well, in the past, we would transfer these patients and say, okay, these patients need to go to the tertiary care center and see if there's something that can be done for them. Well, what we were doing is transferring patients away that were going to succumb to their illness. And that's not as good of an end-of-life situation by doing that, where the patients are away from their loved ones and away from, in a strange hospital, from strange nurses, and the trauma of getting transferred from point A to point B, when everybody knows that just sometimes people don't get well. This provides a stronger community benefit that we can do by doing that. Okay, keeping patients close to their support system is very, very important. You know, there's a lot of healing that goes on with patients if they can be near their loved ones. Now, if Grandpa got transferred to another hospital, sure, Grandma would go. She would make things. What's going on here? Wow. Okay, I'm going to keep. Comes back up.
Sorry, Doug.
Anyway, all right. So I just had kind of a glitch. I don't know if anybody else saw it, but we did. Anyway, if Grandma could go be with her husband, that's great. But you know that the grandson or the son or the daughter couldn't be with their husband because it was too much for them to take the time off work and travel and stay in a hotel and eat out in restaurants and things. So for that whole piece to be able to keep the patients locally and have their loved ones help with their recuperation really does make a difference, and people have better outcomes. So this is our payer mix for what we did in the ICU, and the reason I'm showing you that is that there's self-pay of 6.7%, and that means that 7 of the patients that we prevented transfers on saved $28,000 because they would have had to pay that somehow or some way. They would have had to pay that, and that if you take the Medicare and the Medicaid, those are funds that we are paying out of our own pockets as taxpayers. And for that, we've saved $1.5 million. This is just one hospital in 5 years has saved $1.5 million by providing telemedicine coverage for patients in our community. If this was replicated throughout the country, we would save billions and billions of dollars, and it is possible to replicate it through the country. You can't just get a robot and get a contract and start doing intensive care medicine. This is just a brief example of one of the flows that we had, and this is the flow for the initial evaluation. We have a flow for the handoff at the end. We have the flow for the daily checkoff, for report, all those things. And it's quick. This was 2008. It's interesting how quick things change, because this talks about putting the robot in front of the x-ray view box so they can look at the chest x-rays. Well, now we have an electronic medical record, and the physicians are able to access that electronically and look at it through the PACS system. And so that faxing of records is not quite as intense. Okay, clearly our remote ICU enhances the patient safety initiative, and it's positive for everyone. I want to tell you a little story. At one time when I was doing this, whenever the robot lights up, I get a little email that says, you know, the advanced ICU is on robot 1201, just kind of tells you that that's what's going on. Well, when that came up, one day I walked upstairs just because I had a second. I walked into the ICU, and I got into the middle of a conversation between one of the intensivists in St. Louis and a patient who really didn't want to stay in LeGrand. He didn't want to stay in the hospital. It wasn't LeGrand. It was just, I don't want to stay in the hospital. I've got better things to do. And he'd already had this conversation with his internal medicine doc. And so the intensivist was on the robot on the other end, and I hear him say, uh, sir, the reason you're in my ICU is that you have a very, very bad pneumonia. You need intravenous antibiotics. And if you don't get those antibiotics, you may not survive this illness. That's why you're in my ICU. And this physician wasn't being arrogant about his ICU. It's that he is in that ICU so often, knows the nurses, knows the rooms, knows the physicians that refer to him, and is part of our care team. And he felt like it was just as much his ICU as if he was working here in LeGrand. And I thought that that was pretty profound, that this physician felt such a strong linkage by being a telemedicine provider that he owned the ICU in LeGrand, and he'd never been there in person. Um, the other thing that we do is the sign language, and it works. It's a CMS regulation, Office of Civil Rights. You have to provide this care. Now, what you're seeing here is on the one picture there is the interpreter in Seattle, and she's signing via the telemedicine screen camera to the patient on the other end, and that actual is a deaf patient here. And it was a video that we did that was for our patient safety video, and we were explaining to patients when they come in, we have a video that we play, and we were explaining to them that you have language services available, and we do foreign language, and you know about checking your name and birth date and signing your site for your surgical procedure and all those kinds of things. But while we were getting ready to do this video, I was in the room by myself where we were going to shoot this, and the deaf lady walked in, and she was not a good lip reader, and I'm not a good signer, and I had to tell her to take her clothes off and get in bed, and making the motions of take your clothes off and get in bed, and you can leave your underwear on, and it was very difficult, and I started to write it down and give it to her, and just about that time, the lady on the sign language lady got on the robot, and I says, could you please ask her if she would please take her clothes off, leave her underclothes on, and get into bed. And just in about 10 seconds, that was communicated clearly. The lady went into the bathroom and did what as she was requested and got into bed. So can you imagine what that's like as a caregiver trying to communicate with somebody via pencil and paper? It's way better to have this available, and they're available 7 by 24 with 15 minutes notice. They're in our hospital taking care of the deaf people. You can see that's how it looks. This is if we were in real time, I could show you a video of how this all came off. But this sign language person is on the robot, and that's our nurse, and they were giving medications, and she was telling him what their name and birth date was, so we could do the 5 medication rights. Once again, things changed quickly because now we use barcode administration for our medication administration, but you still would need sign language if the patient was deaf. We have a very successful oncology program, and so much so that we had saved more than the total circumference of the earth in 16 months of patients not having to travel to get their treatments done out of town. We started out doing telemedicine with a physician in Walla Walla. This was part of our remote presence healthcare network. He had a practice in Walla Walla, and him and another doc used to come to LeGrand every other Tuesday. So we had coverage in our community every Tuesday, alternating doctors. And after a while, one of the docs got very tired of driving over the mountain in the snow and having to leave a couple hours early and getting home a couple hours later. You know, it was dark when he came to work, dark when he got home, and he really felt like it was too much. And he told the nurses down in the oncology clinic that said, I can't do this anymore. I could only come once a month instead of twice a month. And so that meant that a lot of patients would have to travel there on that every other Tuesday to Walla Walla. So I brought Dr. Bronstein a laptop and said, "Doctor, would you consider doing telemedicine visits on that opposite Tuesday so you could stay in your clinic?" He said, "Sure." Well, I think that telemedicine is a relationship builder, and the relationship that Dr. Bronstein built by doing telemedicine visits in LeGrand helped us, um, helped him make a decision to move to LeGrand and become employed at Grand Island Hospital. And it's been wonderful to have him. And now we're continuing our telemedicine coverage, like I talked about earlier. When he's not available here, the docs from Boise cover him via telemedicine. And this is one of our devices. This device here is not a robot. It's the same technology, but it is the one that we use in our clinics. It's called an RP Lite. It's a fixed head thing, and it can move, and the camera can go up and down, but it just doesn't drive itself down the hallway like the other devices. So this is an update. My slides can get kind of old quickly, but this is an update from a few months ago. But right after April, our doc was gone in April, and in just 9 days, 19 patients saved 5,300 miles and 87 hours of travel time. Now, the last thing you want to do is, when you're undergoing chemotherapy, is to have to sit in a chair all day and get your chemotherapy and then drive over the mountain. And that's what happens. That's what happened before and what could happen without telemedicine. Now, we do the NRC Picker survey, and these are not made up. These are actual patients' comments on what it meant to them to have their cancer treatment done locally. And it was big. And this one is really profound here. It says, as a single mom, that took the biggest fear of treatment off my mind. How was I going to support my family while battling cancer? She was able to do some work, take an afternoon off or a morning off or whenever it was, get her treatment, and she could go back to work from whatever kind of a job she had. But if she would have had to travel 86 miles one way, she would have had to take the whole day off. And it whips you. You're not feeling like driving if you're the one getting chemotherapy. So we also do teledermatology with a different outfit out of Walla Walla. And this is somewhat stale slide too, in that the miles are more and the patients are more, but we've saved from the very tip of Alaska down to the tip of South America, that's 15,000 miles, and we've saved almost 50,000 miles. And so they've gone from the tip of Alaska down to South America, back up and back down and partway back up. And we contend that patients will seek earlier treatment if it's available to them. They may not go make an appointment in a different town and get their treatments. Now, what's in it for us? Our teledermatology program, the way we do this is the dermatologist pays us per visit in the clinic to use our nurse and to use our equipment. And then what's in it for us is about 30% of those patients are referred to one of our surgeons for either an excision of a lesion or freezing or further treatment. So it works for the patients and for us and for the dermatologists. It's just been a very successful program. How it works is we let the distant site, or the distant site schedule, we give a distant site like Tuesday afternoons or Monday afternoons or whatever, and they'll block the patients in, and then we'll know that we have this group coming to use our clinic for outpatient services on this day, and then we coordinate with them after the patients have made their appointments that, well, okay, we got one at 9, one at 9:45, one at 10:15, that type of thing, and that's how we do it. And once again, the availability of the electronic medical record really helps. It helps ease the communication, not this faxing back and forth and entries. And our nurse in the clinic, at least for the dermatologist and the endocrinologist, she will chart in their electronic patient record the admitting vital signs and chief complaint, that kind of a thing. And then when the doctor logs in on the telemedicine device, she can pull up on her other computer exactly just as if she was in her own clinic doing it. So it's worked out very, very well. And the patients are very satisfied. This is a picture from a video that we have for a neonatal intensive care. And this was, if you could imagine the neonatologist standing there doing a narrative of what all these tubes and lines are and how your baby looks really good because he has great color, and how that the breathing tube is going to come out in the morning, and things are just real fine. Don't worry, mom, we're going to take good care of your baby. That was an actual encounter. I just happened to be in the room when logging in, and then the neonatologist was there, and this was not a planned thing. He just did a visit with the mom and went, and he presented it so well, and it was not scary at all. And this mom was so relieved that she was able to get this information from him and help bond with her baby by not, even though she wasn't there. We've had patients who the neonatologist has consulted on and says, this one can stay. No, this one needs to go. I can look over your shoulder while make sure that the umbilical artery catheter is in the right position. Those types of things. It's just a relationship builder, and it really helps everybody. Sorry about the noise again. The helicopter's taken off. One of our very successful programs is our telecardiology services. This is in conjunction with St. Alphonsus Regional Medical Center in Boise, and we've been able to do many, many things that help patients stay in our community. We've had ER consults, we've had ICU consults, inpatient consults, outpatient visits, and pacemakers. And the latest thing we're doing, and it's working out very well, we did one yesterday, is stress echocardiogram. I believe that we're one of the first in the nation to do stress echocardiograms, and how that works is the patient gets on the treadmill, or how it works is the patient comes for a stress test. The ultrasonographer does a baseline echocardiogram reading, selects the images. The hospitalist, who's an internal medicine doc, comes in and supervises the stress test while the patient's on the treadmill. At the same time, the cardiologist beams in from St. Alphonsus and observes and visits with the doctor and the patient. And then as soon as the patient reaches their maximum heart rate, they stop the treadmill, they put the patient on their side, and take images of the heart when it's at its maximum heart rate. And the cardiologist is able to see real time if there are any defects, if there are any issues related to the patient not being able to go home for a rule out MI. And it has worked very, very well. And we're very happy that St. Alphonsus cardiologists are so forward thinking in moving this forward. And you can do this anywhere in the world. What this is right here is a live echo where John the Echo Tech this patient has a heart defect, and this is a cardiologist on the robot from Moscow, Russia. You can see his head, he's the male. He does not speak English, but the lady over there looking over his shoulder is the interpreter, and so they are doing the echocardiogram, and this was not a real consult in that we were demonstrating that it can be done to this Russian cardiologist. And he says through the interpreter, I see it and I understand. And then he asked, can you do 3D reconstruction? And we can't do 3D reconstruction. And we thought we were showing this wonderful technology to a group that didn't have anything, but apparently they could do 3D reconstruction. So that's our echo, and you can do this telemedicine anywhere in the world. Okay, the latest program we've started is a Nocturnist Hospitalist Program. We have 4 hospitalists in our remote area. They're on 2 at a time. 2's on one week, and then 2's on the next week, and they alternate call on the week they're on. Well, one of the 2 sets are a couple. They are, husband and wife. And so when they take their vacations, they take their vacations together. We're able to backfill with doctors from our clinic who used to be hospitalist doctors, but we started primary care medical home, and we've also lost one internal medicine doc, and it's really a push to try to get him off so much. So what we saw this coming, and so we have contract with a group called Eagle Hospital Physicians in Atlanta, Georgia, and they do Nocturnist Hospitalist Program for us. And the first week that we did this, we had doctors that are all licensed in Oregon, credentialed at Grand Island Hospital, and they live throughout the world. They don't live throughout the United States, they live throughout the world. And the first 4 admits we had that week from our hospitalist was from a doctor who lived in Paris, France. And one of the admits was to the ICU, and the patient, I was talking to a nurse this morning, and she said, "You should have seen that patient. He was saying, 'This is so cool. I can't wait to tell my friends about this. This is awesome.'" He was really excited that he got to be taken care of by a doctor in Paris, France. Anyway, this is another example of the electronic medical record. When we set this contract up, these doctors were not to write holding orders. They wrote no holding orders. They did full admits. They were to do CPOE on all admissions and all orders, no verbal orders, no telephone orders. Never did anything. All was electronically done. They had to do medication reconciliation, done. They had to do home med list, done. And so our ability to have electronic medical record opens up telemedicine worldwide. Another one of the physicians that's in the same group lives in Israel, and he's getting his privileges at Grand Island Hospital now. He already has his Oregon license. So it is pretty amazing that you can do this with the technology. It's rock solid. So it really is the standard of care, and you will. It won't take long before people are going to be asking, well, why didn't you consult a specialist if there was one available? And so we're stepping outside the real dark line box, but that dark line box has a lot of softer lines around the edges. And we've been successful, and we think we're doing the right thing. Oregon, I'm also been honored to be part of the Telehealth Alliance of Oregon group, and a few years ago we were able to successfully present, promote, and testify to the Senate and House on telemedicine reimbursement. And Oregon does now have a telemedicine reimbursement law that basically says that insurance companies, if you pay somebody to be seen face to face, you're going to pay for it telemedically. And that's thanks to a lot of people's efforts that help this get done. And I'm very proud to be part of that very important group for moving telemedicine forward. So, you can do some things, and you can get some awards, and we can enjoy the notoriety of getting those awards. But that's only a sideline of what we're doing. We're doing what's right for the patients. We're providing access to high quality, cost effective healthcare in a customer friendly environment. And it's accepted by the patients, accepted by the medical staff, and it just works. So ladies and gentlemen, I thank you for being here and listening to my stories. And I'm happy to answer any questions if you have any. We got probably 5 minutes.
Well, thanks, Doug. It's always interesting to listen to your presentations because you keep them updated and you really show how a small hospital in a pretty remote place, and I know it's remote because I drove there from Billings last week, can provide world-class service. And everybody who's listening, if you have questions for Doug, you can go ahead and type them into the question and answer pod. It looks like you need to click on the little icon on the right side of the 2 icons so you can enter data, and then you hit your enter key. That will show up for Doug. It was interesting to hear the helicopter coming in and going out. Doug took me up to the helipad the other day and showed it off. It's just a brand new pad. They used to land at the football field over at the high school. So things are moving upward, that's for sure. Once again, if you have questions about how a critical access hospital can provide telemedicine services for its local patients, here's the place to ask those questions. Otherwise, Doug will say thank you very much, and we'll
copies of these slides are available. Right, yeah, down here on the NRTR, where is that? Oh, over here on the left where it says PDF. If you download that, Joe, you can get the copies of the slides.
Yeah, you're welcome to download those slides. If you have questions for Doug that you'd prefer to ask quietly, you can always email me and I can relay them. And I see we have a question for Denny in the chat module, Doug.
Oh, yes. Okay, Doug, wondering if your hospitals are actually admitting patients. Absolutely. They're doing the full admission. They're doing it. And it works fine. I think we admitted 6 patients that week. We have the a night hospitalist scheduled for 6 more weeks coming up here in about a week or 2 weeks. So it's working. Um, our nurse practitioners are not involved in telemedicine at this point, but they could be. It's just that the providers that we have been using are MDs or DOs. Um, yes, it keeps patient. I'm reading Denny Lorden's. It does increase our census and our patient days, and we are critical access. Um, that's really good to increase your census and patient days until you get up towards the cap. Then you don't want to do that. But more importantly, it just keeps people in their local community. And we contract with our hospitalists. Our hospitalist program is a group. It's called Eagle Hospital Physicians in Atlanta, Georgia, and they broker these hospitalists who are all part of their group, and they offer locum tenens and telemedicine and nocturnist programs. And Dan, call me if you want me to get you in touch with them.
And Doug, you've kind of turned the whole hub and spoke thing on its head, haven't you? Grand Rod has actually become the hub of the system that you've built just by working with a lot of different providers in a lot of different areas.
Yeah, right. And we are reaching out to the hospital, the 4 hospitalists that we employ. In their contract, it says that they will provide telemedicine services to hospitals in our region as needed. We haven't quite got there yet, but should we find the opportunity, we will be able to provide hospitalist services that way also. And when we signed up with the Eagle Hospital Physicians for the night coverage, they are willing to also back us up for night coverage if we do it somewhere else. It's just a network.
It's just the connection, isn't it? And that's what's so important. And that's the thing that we see oftentimes critical access hospitals miss that point. So it looks like we've got another question coming in, Doug, in just a minute here. And
I see one from Vicky. Um, we How we work it with the ICU docs is they are on retainer. We pay an annual fee to have them on call, and then we um, pay a per consult fee up to a certain amount of time, and basically it's per day consult fee, and we don't bill for that. We could bill those consults, but then we'd have to. There's 18 intensivists on staff, and it would be pretty complex to get all 18 of those on all our provider panels. We feel that it's just good to keep our ICU full or keep patients in our ICU. It raises the bar in our ICU too. It keeps the nurses very comfortable with taking care of ventilator patients instead of doing it once a month. They're maybe doing it once a week.
see, Denny slipped in a question about locums and the cost of telemedicine coverage.
Well, that's a pretty much a no-brainer because when you're paying locums, you're paying the doctors and you're paying the locums company, so you're paying twice. It is less expensive. Yeah, they do provide they do their assessment orders via EHR and CPOE. Let me tell you one little thing we're working on that, which is kind of a catch. We are squeaky clean with our electronic medical record, and what it says is that passwords will expire every 90 days. And so we have 18 intensivists on call that rotate through that, and we do, 2 or 3 patients a month. And so it may be a few months before those docs circle back through and are on shift when we have a patient, and their passwords expire, and then they've got to call in and get their passwords reset, and it makes it a little bit difficult for the EHR thing. And so what we are exploring, in fact, on Monday, is the opportunity to use these little tokens that I'm not sure how it works, but our IT guys have. Well, it's a server system that the intensivist can use the token that generates a password for them, and so their passwords won't ever have to be reset, and so that's going to be real consistent. Sometimes they have to write, when that happens, sometimes they end up writing procedure notes and some verbal orders, um, but they can get, more times than not, get into the EHR.
Okay, I don't see too much more activity on the chat windows, but we'll give just another minute or so in case anybody has any questions. Doug, thanks a lot. Thanks for this presentation, and I know your schedule is just slammed, and I appreciate you taking the time out to join us. And looks like we got one more comment coming in, and I agree with that. So everybody, thanks for joining us. Martha is going to take over your screen and ask you to fill out a survey to tell us what you thought of today's webinar, and as importantly, to tell us what you'd like to see in webinars. NRTRC is dedicated to bringing education and information to all of our friends in all of our regions. So please let us know what you'd like to see, and we'll do our best to schedule it for you. Doug, thanks a lot. Everybody, thanks for attending.
Thank you. See you later.
See ya.